The next speaker, Don Ponec, returns to review the Del Mar experience in the Hubbard trial.
You know, when we had the patient day the other day, we talked a little bit about the outcomes of the liberation procedure. So if you were there for that, you might see a couple of the slides that are on here. And we talked, I think, amongst us about the problem with calling it a liberation procedure, and that it's a term we don't use in our practice just because the implication is probably giving the wrong impression about this, and it's probably just semantic, but the idea that you're sort of suddenly released from this oppressive once and for all, you know, and that may not really be what this procedure does. If it is, we don't know that yet. So I'm going to talk about clinical outcomes of CNS venoplasty in MS, and this is a single center efficacy trial. I'll tell you more about that. Since my earlier talk, I have developed no financial relationships, and the clinical outcomes, our trial anyway, is an extension in a way of an earlier functional MRI trial, and we continued data collection on patients who underwent MR venography and then subsequently catheter venography and interventions, and I'm going to tell you about some of that. This is not a randomized controlled trial. That's what we're all agreeing, I think, at a certain point we're going to need. But yet, there's a recognition that in medicine and that we don't often, if ever, start with a randomized controlled trial. There's observations and then further observations and case studies and series and eventually registries. And one thing about a randomized trial is that in order to do that, we have to kind of know what we're going to be looking, you know, what are we going to study? Who's going to be in it? What is the study population? What's the technique? It has to be a standardized technique. We have to do the same thing every time. We haven't really even agreed on that at this point. We have to agree on what the endpoints are. Is the endpoint a clinical response? How are we going to follow patients in imaging follow-up, look for restenosis? Is it clinical restenosis? So there are a lot of questions. And this consensus panel from SIR, which many of us are involved with, encourages us to do what Dr. Siskin said. You know, when you have something and you're doing it, write it down. You know, submit it so that we can all benefit from what's going on in our practices and eventually get to that point. Now, I don't know if you've ever aware of this, but Dr. Zamboni did a series of 65 patients, and you know, it's about the 15th time this week. But and this is really the only published clinical response or clinical outcomes study at this point, and he did find a clinically significant, statistically significant value in doing this procedure at 18 months, and so that's the only published literature so far on clinical outcomes. Ours is a registry of consecutive patients who, as I said, were qualified by having an abnormal MRV, which demonstrated diminished flow. All the patients underwent venography and PTA when appropriate. Stents were used rarely and only for occlusions that were not responsive, and these were all done in an ambulatory setting. Patients were self-referred. They were not recruited or paid for participation. Again, they had to qualify by having a physical abnormality demonstrated at imaging, and this was the Heike protocol and integrated flow mapping. Patients prior to participation completed a clinical status measurement tool, the MSIS-29, and then subsequently at 1 and 6 months completed that, and that's what we're reporting on. Those are the results from this trial. And this was an IRB-approved trial, started, I guess, about 14 or 15 months ago. The analytical methods were, again, it's not a randomized trial, so we had to rely on statisticians, mathematician types, who could predict what the outcomes would be in the event of no impact of the treatment, including whatever random events are likely to occur given the scale that was being used. And this was done by an independent person. This was the study demographics. This was a while ago that this data was tabulated, so it was 265 patients. The expected distribution, 65% female, and about a little over half relapsing and remitting, and the other primary progressive and secondary progressive, about a quarter each, roughly speaking. So this MSIS-29 scale it's a survey that the patients complete. This is not administered by a neurologist. It has been validated as a way of assessing disability, but that's important to know. It's generated from interviews and has been validated in a couple of different ways against other known measures. This is the type of survey this is. It includes a two, if everybody knows this, yell out, but it's a look back period. So you can see the types of questions. These are sort of real disability and wellness type questions for the physical, and then on the cognitive side, these questions here, and it's over the past 2 weeks, have you had, that sort of thing. And here it is. I'll show you this in a couple of easier ways to conceptualize it, but here it is in a nutshell at 1 month follow-up. These are the patients who were improved, roughly 76%, and 66% at 6 months. In the world of, when I first saw these, I was thinking, well, that's pretty good. But in the world of multiple sclerosis, this is huge. These are huge changes. These are the sorts of changes that, if you have a few percentage points, those are the ones that, get approval for a new medication in pharma. So there are big changes. If we break this down by the type of scale, if it was the cognitive or the physical scale, those same sorts of results hold up. And here's a way of seeing it more graphically. So this is physical scores at 1 month. These were the improved or markedly improved based on the standard deviation numbers. And similarly for mental health scores. Now the N falls off a little bit here, which we're improving. But we see the same stratification of improvement on the mental health scores that we saw in the physical scores. Here we are at 6 months. And so at 1 month, when we looked at the physical scores, we saw at 1 month, this was statistically significant from the predicted values at a 0.01 level, and the same at 6 months. This was for the physical scores. And then similarly on the mental health scores or the cognitive scores, same thing. Highly statistically significant changes. The next thing was to kind of fulfill this notion of, well, are there subgroups? Are there parts of the population who might have shown a different type of response based on gender, age, level of disability, all of those things? I'll go through these, but the answer was no. They didn't really seem to matter. Everybody showed the same level of improvement, which of course could mean two things. It might mean that that's true. There is no difference. Everybody responds the same. Or it might have been that this particular survey method isn't sensitive to those kinds of differences. But looking to see if gender was a predictor, age was a predictor, no. And even the MS, this was a surprise to me, the MS subtype. So secondary progressive was not really statistically significant from everybody else in terms of their responsiveness to venoplasty, which I think kind of goes against what sort of the intuition is about this treatment. Level of disability or duration of symptoms. There were some trends here. I'll show you some trend lines, but again, nothing statistically significant. And then this is one of these trend lines when we looked at duration of symptoms over time and changes at health scores between 1 and 6 months. You see some crossing over here that might have a little bit of a trend to it, but really nothing significant. MS medication. Now here's another good one in terms of a clinical trial. If we're going to do a clinical trial, if somebody is on Copaxone for 6 years or has started Rebif 3 months ago, are they excluded or are they included? And at least in our experience, it didn't matter. And it sort of raises those questions about where is CCSVI relative to MS? Is it layered on top? Is it the same thing? And how do those things interact? But this of course would have to be validated in other ways, but MS medications didn't really seem to matter. And baseline flow rates didn't seem to matter either. This is the venous flow rates, again, just sort of showing a minor trend, but nothing statistically significant. And the amount of reflux didn't seem to matter either. So it just seemed to be an across-the-board response. Now, restenosis is an important question. We know that restenosis happens commonly. Our restenosis numbers are so-called clinical restenosis, which kind of harkens us back as interventionalists to the idea of clinical patency in peripheral vascular trials, which we know is really not valid if you're looking just at patency. If you're trying to determine if a stent or a stent graft is staying open, clinical patency doesn't get you there. You need to have some sort of interrogation that's active at a certain point. But in terms of the purpose of this trial, we're really only interested in the clinical response. So I guess in that sense, clinical restenosis makes sense, although I kind of hesitate to say restenosis. We did have patients come back because of recurrent symptoms, and 22 or 8.3% came back. 4 patients were retreated at other facilities, and we couldn't get data on those. There was a trend towards shorter duration of MS symptoms and smaller balloon sizes, and this kind of goes along with the earlier reference to Dr. Zamboni's paper. You remember that the restenosis rate was very high, but also balloon sizes were typically 8 or 10 millimeters, so smaller balloon sizes. One patient report of a new MS lesion was noted. We were not able to get 6-month follow-up on that data, and that was not captured on the MSIS-29. This was more of an MR independent report. Balloon interventions per site. This is the percentage breakdown, and it's pretty much what you would expect. The left lower jugular and the right lower jugular segments at the valve levels, that's where most of the interventions are performed. Upper jugular vein lesions were also present in around a quarter of patients. Most patients were getting, I think the number was around 2.2 interventions per patient. So there's typically more than one PTA per patient. Balloon size, these were the ranges of balloon sizes for the upper jugular, somewhere in 6 to 12, and 6 to 12 in the upper jugular, and 6 to 18 in the lower jugular segments. And even stratifying by balloon sizes used in these locations, it didn't really matter, although overall balloon size did seem to matter. We did, as I mentioned in an earlier session, we don't use stents very often. This study of the 260-ish people, there was 2.5% stents, or 6 out of, 240 here. But again, no difference in response rates for the stented segments or based on azygos versus jugular PTAs, although all but one patient ended up having a jugular angioplasty. Adverse events, no serious adverse events in our study or otherwise to date. We did have a patient who was non-ambulatory, wheelchair-bound, who at 3 weeks developed a puncture site thrombus that was treated with anticoagulants. But that's the only adverse event we observed. So overall, there was a statistically significant improvement clinically at 1 and 6 months at a highly significant level. And in terms of looking at predictors of that response, the type, degree of disability, or number of veins involved, baseline flow, didn't really seem to make a lot of difference. It was more identifying a lesion and then treating the lesion. So, in summary, that we're working on accumulating a little bit more data, particularly probing into that 6-month survey response rate. We'd like to get a higher response rate on that, and then and submit this for publication. It would be the second report of statistically significant clinical improvement using this validated tool. Restenosis rate again was listed as clinical, so that 8.3% is not necessarily representative of what we would have found if we had done more active investigation on those patients. And again, the outcomes we fear might be skewed by the incomplete response, and that's how we're addressing that is by going after those responses. And that is